welcome in nursing webinar session. Myself Shanti, the VP Nursing, and today we are going to discuss about the bariatrics, the Whipple procedure and its nursing management. And having said so, let me welcome the very eminent expert panelist, none other Dr. TLVD Prasad Babu Garu, who is here with us at this forum. He's our senior gastroenterologist and hepato pancreatic biliary specialist, and many more advanced GI surgeries he's specialist with. And let me also welcome Ms. Suneetha, who is our nurse manager from Secunderabad, the Yashoda Hospital. So moving on to the first slide, you can just share the first slide. Sir, it is, we are very privileged and happy to have you in this session.
Thank you. Thank you very much.
Thank you, sir. And can you share the slides, Suneetha? Yes. Yes. As sir, by the time Suneetha shares the slide, we can't see the slide. Yes, you can share the slide. So as the say goes on, sir, that does Whipple procedure, improves the survival or life expectancy of the patient, sir, as you're a Whipple specialist?
Yeah. See, I think Whipple surgery is done for some indications. I think she is going to tell what are the indications on the following slide. So the only way of cure or prolonging the disease survival in a pancreatic malignancy or in a periambulary malignancy is surgery only. So the surgery is a very important pivot in this management of these tumors.
Yes.
Despite doing surgeries also, definitely the survival rate is less when compared to other malignancies. You all know that pancreatic cancer is one of the deadliest malignancies. But the 5-year survival after surgery, after taking therapies, somewhere it comes around to 10 to 20%, less than that, 10% like that, 5-year survival. But this 5-year survival also we can achieve only with the help of, if you do a multimodality treatment where you do surgery and followed by, if required, a chemotherapy, all this, with that only you can achieve those results. So surgery plays a very crucial role in the management of pancreatic cancers. And especially if the cancer is involving the head of the pancreas, there is no option then performing a Whipple's operation.
Yes, sir. So it is very great to hear that, and we have finally the slide. Yes, you can go to the first slide, Suneetha, as quickly. Yeah.
Yes, ma'am. Thank you, ma'am. I'm Suneetha, Nursing Quality Officer working in Yashoda Hospital, Secunderabad unit. I'm here to discuss about Whipple's procedure. Whipple's procedure or pancreatoduodenectomy. It involves removing the head of the pancreas, pancreatic cancer, first part of small intestine, gallbladder, and bile duct. Whipple's procedure is a complex procedure and it takes more than 6 to 8 hours.
So, sir, as we are looking at the slide where the pancreas, small intestine, bile duct, gallbladder, every part or gland or ductal features are involved. So, any patient there with all the features which is involved, or only the head of pancreas, or different cases?
Why? See, basically, you can have a small tumor where I'm showing. I don't know whether you would be able to see if I do a cursor on this. I don't know. Okay.
Yeah, Suneetha, you can do the cursor. Yes.
That's okay. That's fine. Okay, that's fine. So, yeah, that's it. I think. Yes. So, if you have that tumor, why to remove so many organs? Because the pancreatic head and this duodenum, they share a common blood supply.
Yes.
So you cannot remove this structure as an isolation. That is the reason if any thing involving like head of the pancreas or bile duct cancer or a duodenal cancer, what you have to do is you have to remove this segment as a block. That means you have to cut the bile duct along with the gallbladder. Then you transect the stomach. Then you transect the proximal jejunum here. Then at the pancreas transection, this segment. Individually, because of the complex blood supply between these organs, you cannot remove as a single organ like that. So once you remove this as a block, then you have to do again the joining. That's, I think, 3 joints, because you have cut the bile duct, you have to take a bile duct anastomosis, you have cut the pancreas, you have to make an anastomosis to the pancreas, and you have discontinued the stomach continuity. So you have to join the stomach with the small intestine. This is so here. Lot of things. What happens is surgery. The problem, major surgery also happens after remove the tumor, because again you have to do a reconstruction, which is also very, very important. I say that is more important than removing the organ actually.
So the reconstruction is done post-surgery during that time itself.
Yes, once you remove the tumor, then we do the reconstruction. Yes.
That is, I think that is how the surgery takes longer duration. Yes. Yes. Yes, proceed, Suneetha.
Yes, ma'am. Next, we will move on to the indications. Why surgery is required? If the patient is having carcinoma or tumor or cyst at the head of the pancreas or carcinoma of the duodenum, otherwise the patient is having trauma to the pancreas and small intestine, and ampullary and bile duct carcinomas.
So, sir, these patients, when they report to you, maybe in the OPD or they come to the, to your OPD, so do they, is it, diagnosed within the time period, or they have already exceeded maybe like few of the patients, or as per your.
Usually, good number. Good number of suppose in pancreatic cancers, resectability rate, the people who reaches to the operation theater it is around only 20 to 30% of the cases only. Majority of the presentation by the time they come to the clinician, they are not in a position to in operable status, because it can be, they might be having a distant metastasis somewhere. If you have liver metastasis, lung metastasis, and all those patients, we don't do surgeries. Definitive surgeries. Again, certain patients can have a local involvement of major blood vessels involvement can be there. Those sort of patients might not be possible to do an operations. So here, these usually they present with jaundice or some other symptoms like pain, jaundice or bleeding, anemia. These are all the common presentations. Then once they reach the clinician, we do workup with the help of an endoscopy, ERCP, CT scan, MRI, all these tests we do. Certain times we do a whole body PET CT scan to rule out metastasis. Once we do a diagnosis, proper staging, then we look out for the various modalities of treatment.
Yes. Yes.
So as Sir is explained very well about indications, hope you all understood. So furtherly, we are going for, it's a real case scenario of a patient, 65 years male. He had already known case of carcinoma head of the pancreas and post status of PTBD, which means percutaneous transhepatic biliary duct drainage, and post status of neoadjuvant chemotherapy. When it's come to his risk factors, he doesn't have any comorbidities. He didn't have any diabetes, hypertension, as well as hypothyroid and all. Even though he doesn't have any family history also. So he stayed in our hospital, Secunderabad unit, the 9 days with us. Initially, he was admitted with the symptoms of upper abdominal discomfort, vomiting, yellow color urine, intermittent fever, fatigue, and weight loss. Within a short period of time, he lost 2 to 3 kgs of weight.
So, sir, here this was a very wonderful case was treated by you, and you gave him the very productive outcome. So here, as we are looking at, if the patient has patient had to take the chemo, how long post chemo the patient has to wait for the procedure?
So actually, this is the patient with carcinoma head of the pancreas. It was, we call it is locally advanced disease. Little advanced nature of the disease he has, where this patient had involvement of the superior mesenteric vein, portal vein complex. It was involved by the tumor. Okay. So that's the reason in these advanced patients, what we do is today, we first treat these patients with the chemotherapy, such that if once you get a response, after surgery, we will get a clear margins. All we call as R0 resection margins, we will get it. And the results are better if you first you treat this patient with neoadjuvant therapy and do a surgery, you get a good margins and all. Not only that, it also gives some indication about the what you call as response to the chemotherapy, how they are behaving. Those things also will come into picture. But to start a chemotherapy, there should not be a jaundice. This patient had a jaundice. So initially, our gastroenterology colleagues, they tried doing an ERCP through the endoscopy. They tried putting a stent. For some technical reasons, it was not possible to put a stent. Then we took the help of the interventional radiologist. They did a percutaneous biliary drainage from above. So especially here, the drainage was required for two purposes. One is he has a fever also. So to relieve from the cholangitis, that is infection, and also to alleviate from the jaundice. Once the jaundice settles down, then only our chemotherapist, medical oncologist will give chemo. So here in this patient, we are given chemotherapy for 2 sessions of 2 cycles of chemotherapy we are given. Then we waited for 6 weeks of time. Then we did an imaging and assessed the response. Then we did the surgery on this patient.
Yeah, it is quite very interesting. That is how I think we urge all the nurses to just read the progress notes which has been prescribed by the consultant, as you will likely to see the progress, how, why, and what ways we have done one intervention procedure and then drawn the patient to the surgery. Very clear, sir. Thank you. Yes, Suneetha, next slide.
Yes, ma'am. So next we'll go to discuss on physical examination. Apart from the signs and symptoms, doctor identified icterus on patient and patient is having febrile. There is a temperature is more than 100 degrees Fahrenheit. Other vital parameters are normal for this patient. And the same thing has documented in the doctor's initial assessment form. You can glance here in this slide that the symptoms already documented and the systematic deviations also documented in this initial form.
Yeah, you can go on. Yeah, continue.
Yes, ma'am. So apart from this, the patient radiological images has done for this patient. When it's seen in the PET CT scan, they identified that mass at the head of the pancreas. When it is a CT scan, they find out that the pancreas mass is infiltrating pylorus duodenal junction. So you can see in this picture. So in the PET CT scan, I'm scrolling on the means you can see that is a cursor is moving. So this is a mass they have found out. At the same time, there is the same picture in the zoom way. So here also that is a green circle was marked. Here also is a mass. And in this come to infiltrating pylorus duodenal junction, you can see here that is the head of the pancreas mass and it is infiltrating the duodenal junction.
So, sir, for this case, that is how, as the reference of the images are seen, that is how you got to operate even on the.
Correct.
Yes, sir.
Correct.
Yeah, move.
Yes, ma'am. Next, coming to this, apart from this radiological investigation, patient also was earlier explanations already, sir is explained that endoscopy also they have done. So they have through endoscopic guided, they have taken 2 biopsies. One is from head of the pancreas, other one is from duodenal junction. The both biopsies were positive for malignancy tumor. At the same time, they have done the ROSE test. It is also positive for this patient. The ROSE is nothing but rapid on-site evaluation. It is one kind of biopsy method. There they have collected the tissue from the growth and they used to stain with the theodolin and they used to find out the abnormal cell growth. And also the patient is having a cancer marker positive, that is a cancer antigen 19 to 90 is high. It indicates the pancreatic cancer.
So, sir, if we talk about the ROSE, which is again quite new for us, and maybe this is a pancreatic tumor marker, including the cancer 19 to 9, sir?
99 is a marker. ROSE is where our endoscopist or medical gastroenterology doctors, nowadays they do a biopsy with a method called endosonography,
Yes.
where they take an ultrasonography machine perorally then they take into the stomach. From near to the stomach, they try to biopsy the lot of tissues, pancreas or bile duct, stomach, deeper biopsies. They can able to take through the endosonography. So what they do is immediately after they take the sample, there will be a pathologist who will be there. We have a technique called rapidly they will evaluate and they look for malignant cells. So that is called ROSE, rapid onset evaluation. Then this is further, it will be again, definitely evaluated in the final biopsy. So initial biopsy itself, it has given an indication that there are malignant cells in this patient.
Okay, sir. Thank you for highlighting these advanced technique which we have at our
Yes.
facility.
Next slide.
So based on the results, surgeon was decided to perform Whipples procedure, that is Whipples pancreatoduodenectomy with pancreato, hepato, gastro and nasojejunostomy with anastomosis, end-to-end anastomosis under general anesthesia. And as for the pre-op checks, the nurse should ensure here the patient kept on MBM or not, and PACs, that is pre-anesthetic checkups. She has to ensure whether it is done or not, and consent has to be take part preparation, reserved blood. This is very important because it's a major procedure. They're supposed to be reserved blood, and with all the required documents and reports, the patient has to be shifted to OT, and it has to be handed over to pre-operative nurse.
So, sir, you're convinced with a preoperative checklist, or do you have any instructions to be told to the nurses? You can, please.
Yeah, I think important is in these patients not only consent, also this sort of procedures we take a detailed consent, and sometimes lot of times we do a video counseling also with the relatives. That's what we do. We might not be doing routinely for all the surgeries, but certain major surgeries we do a video counseling and a briefing with the relatives. We spend some time, that is also will be there, while special consents will be taken for these patients. And sometimes we add a pre-operative antibiotics. We might give few doses. Some overnight hydration. We do some this. Suppose if some patients, if they have an sugar, diabetes, and overnight glycemic control is very, very important.
Yeah.
And as she told about reserving the blood and blood products, that is also important. Then handing over all the images, that is very important, because the images, again, the OTT, they want it immediately, they have to check during the due course of time procedure. And that is very important. Of course, we have now in all our OTs are equipped with online, we can see the impacts facility is there. We can see those images in the OR theater itself. But nevertheless, it's the nurse who is taking the pre-operative nurse should hand over all this relevant file reports and also the images to the concerned OR sister. Actually, that's
Yes.
Yes.
Yeah, go on.
Yes, ma'am.
You can quickly flick the slides. Yeah.
Yes, ma'am. And as once a nurse means post-operative nursing care, once the patient is received from a complex procedure, nurse should be more vigilant on monitoring of their vitals, because as soon as we are received, so whatever the vitals is fluctuating hemodynamically, whether the patient is stable or not, so that can be identified through vitals, and it has to be documented the same on the chart. And if any problem is there, if any fluctuations is there, they immediately supposed to be reached toward the surgeon. And in the Whipples procedure, maintaining of intake and output chart is very important, because the patient will be continue NBM till 4th POD. So, and here the intravenous hydration is very important. So most of the cases will be half DNS, they will be infused, and plasmolytes also they will be infused for some patients to prevent post-operative complications. And here it is important to check the GRBS. So as earlier sir said, the fluctuation in the sugar levels that can be lead to again increase in the sugar levels. So the continuous monitoring on the GRBS also is important. And here we should also administer, means post-operatively, the doctors usually will administer, that is a antiplatelet aggravator, that is a Clexin will be given. So that is low molecular weight heparin is example like a Clexin. This patient also used that one. And as much as possible on 0 POD on bed, at least we can encourage the patient to ambulate, and we should encourage the patient to do spirometry exercises. So this practices will be start from the preoperative itself, breathing exercises. We educate the patient before the surgery itself. And last most, that is a pain management. So as you know, it's a major procedure and there is so many drains and the catheters will be there. The patient will be in a lot of pain. So it should be managed with the epidural line. Sometimes it may require fentanyl injections, that is also can be administered. So these are all.
Suneetha, one thing, what is this like KCL correction? Do you
Yes, ma'am.
also follow the cross-check policy when you give, because it is one of the high-risk drug?
Yeah, yes, ma'am. Here, what is the problem means, so probably there will be, the patient is continuously on NBM, there is a chances to get hypokalemia. So to correct that, it's a prior itself, the doctors usually advise to administered injection KCL along with the half NS, otherwise half DNS. So for that reason, they used to administer this. So as per the golden rule, KCL is considered as a high-risk medication. So before administration of this KCL, so the nurse, whoever is a concerned nurse, she has to be cross-checked with senior nurses before administration of this medication.
So, sir, will you agree with all this post-operative nursing care, sir, or do you wish to add something else from your end, sir?
So I
Any
think,
other point?
see, very important is a lot of our patients now after Whipples procedure, they directly come to the ward from the OR actually.
Yes.
So the reason being is all our staff in our ward, they are trained for those things, and more than 90% of the cases we don't keep the patient in the intensive unit. Straight away from the OR, they come to the ward, normal routine ward they will come. So here the important aspect is they stay from 3-4 hours in the recovery room. From the recovery, they come to the ward. So handover they should get from proper handover from the recovery nurse to the ward nurse. So in these major procedures, they should spend some time, take a proper over. That's what they have been doing, and they are checking with that. And you have to ensure the way she was talking about labeling the drains, and they keep an eye where are the drains are there, what are they, and check for the color of the drains.
Color of the drain.
Very, very important. And especially on the day one, immediately suppose by the time the patient comes to the ward, it will be in the evening. That night is very important night for the patient and for the sister who is taking care of the patient, where you have to look for the drains, monitor, measure the amount, keep a tab on what is going on. If there are any fresh blood or some changes are happening, then they should inform to the concerned team of the doctors.
Yes.
And important is the way she was talking vitals, the pulse rate and blood pressure or urine output. These are all the main things. The way we look into in every patient. And here, if you have a jaundice patient, also certain times we operate. We have to see proper hydration, urine output, and you have to take an over about antibiotic dosage when they got away. He received the last dosage, next dosage.
Yes.
Those things he has to check and keep a tab on it. And good amount of patients will have leg pumps, DVT prophylactic pumps also. So once they have to check again what is the functional status of the pumping machines, how they are and all. So the first initial 1 or 2 days we use the pumps till they get proper ambulation. Usually after the next 6 hours we might start, and the way she was talking about low molecular weight heparin, we do it. So we always ask the sister to ensure before giving a low molecular heparin, look for the drains, how they are. If they are very hemorrhagic and all, naturally they have to talk with the concerned team of the doctors. So those are all the senior nurses, they know when to give heparin, and before giving heparin, what are the things they should check and all. All those things we keep on training them and all. So usually they manage very well.
Thank you. And I request all the nurses, the learners out there to just follow the post-operative instructions and please notify the team. As you know, these procedures are very complex in nature, and safe nursing care only is the crucial, phenomena to get rid of this patient from the, danger period. Yes, continue.
Thank you, sir. You enhanced post-operative care very well in a manner. So hope the staff will be follow the same in further, sir. So coming to the POD 1, here we have to continue the patient to ambulate, and we also continue intravenous fluid and NBM. And here it is a more important thing is that in the POD 1 onwards, drain care is very important. The nurse should ensure that the prevention of accidental denailing. As we already informed that the patient will have more drains and more catheters. So the nurse should be ensure that whenever he is handling, whenever you are measuring the drains, whenever you are clamping, when you are unclamping, and whenever you are taking care about the patient for the movement or anything, so they have to be more conscious to be take care of about drain care. And secondarily, aspiration also will be very important to be do to empty the stomach. And second POD, the alternative days, that is a CBP and serum creatinine and electrolytes, alternative days it is advised to monitor that is any fluctuations in the serum electrolytes and any CBP deviations. And even dressing also alternately is required to be do to prevent surgical site infections.
So, sir, if there is any blood loss or anything like we see the borderline HB and all, we can transfuse the blood also during the post-op period. Yes.
Yeah.
Yes.
Usually nowadays with the advancements in the surgery, the energy source what we use during surgery and all, we hardly lose much blood with
Yes.
surgeries and all. We rarely come across blood transfusions in this sort of scenario, unless if the patients are having very borderline hemoglobin after the major surgery. Very rarely, very few patients they will tend to receive some blood products. But as she rightly told that we keep a tab on the patient's CBP and look for hemoglobin drop and all. We suppose in case required we might transfuse, but usually it is not so.
Yes. Yeah, quickly go for the.
Okay, next let us see on POD 3 and 4 we can be remove drain, suction drain and all, and we can be start with the NG feeds. So whenever we are starting NG feeds, we should ensure the patient tolerability, whether he is able to tolerate the feeds. So that is what we will be start with a very minimal amount, that is a 30 ml per hour. So if the patient is able to tolerate, on 5th POD, we can increase the volume of this feeds up to 50, then 80, then gradually we can improve that. Even that is a fifth POD, we can also remove the suction drain, Foley's catheter and central line. And if we have, once we have removed the catheter, urinary catheters, we have to encourage the patient to pass the urine. So that is the most important thing, because if we are not encouraging the patients, that may again will lead to urinary tract infection and retention and will cause. And even the following day, that is the 5th, 6th POD, we can stop the NG feeds and we can encourage the patient to take oral clear liquids. That is also from less quantity to, we can gradually increase the dose. That is a 30 ml per hour to then 50 ml per hour, then again 60 ml per hour. So whenever we are giving feeds, the nurse should ensure the patient's position. It should be an upright. It's a very important, that is a 30 to 45 degrees angle position. We are supposed to keep the position. That can be prevent patient's aspiration.
So, sir, this is all your guided protocol, what we follow at your facility. This is all your post-operative care which you are.
Yeah, basically what we do is we focus on quick ambulation of the patients, resume to the oral feeds. Especially initial days we do nasojejunal feeds, we'll just start and all. Once they accept it, and slowly we switch on to the orals. I think once they tolerate, we decrease NJ feeds and we send the patient. Usually day 6 or day 7, we discharge the patient on a oral liquid diet. That's what we been doing and all.
Okay.
So next will be.
Yeah. Go for the 13th slide.
Yes, ma'am. Next, we will be going with that. When the nurse should approach to the doctors, means if any issues, like as earlier sir said, if any urine output is less than 30 ml per hour, otherwise the BP is very less, that is a systolic BP is less than 100 mm of Hg, or any drainage or oozing or any fresh bleed from the surgical site, or if the patient temperature is increasing more than 100 degrees, so the nurse immediately should approach the doctor or escalate the issue to the doctor and take the consent from the team doctors otherwise, and immediately they have to escalate the issue to the consultants. So this is a very.
Go forward, yes.
So in last, we'll discuss about discharge advices. So means probably the cases 7th or 6th day they will be get discharged. during the discharge time. So we had as a nurse, we have to emphasize on education to the patient. So we have to educate on timely medications, discharge medications, whatever it is written. We have to timely educate on medications and encourage the patient to do spirometry at home. And we will also educate the patients how to give NG feeds at home and full liquid diet. And here the patient is having less absorption problem. So for that peptide product, it is suggested by the dietitian. Here we usually use for this pancreatic duodenectomy cases. This we have to ensure that at least the patient should receive 12 scoops per day in a divided doses to prevent malnutrition after the procedure. At the same time, we also educate on drain care and measurement of the drain.
So sir, if the patient goes with a drain and they are taught how to measure and all, and they get back to you.
Yes.
Yes. So I think some patients we remove few drains and send, and some patients they might go with 1 or 2 drains, they go home. So there we ensure that to properly label the drain, which drain it is and all, they will ask them to make a proper chart out of it, and they should inform us if there any change in the drain color or quantity, if there any issues and all, we'll ask the patients to inform us. And nowadays we have technological advancements where they do take a photograph and send the photograph to WhatsApp to one of our team members. Or certain times they do make a video calls from home showing the drains and all. So one of them, our team member will take the call and look into that, and we'll advise accordingly, we'll do it. So the next we will give at the time important not only these medications, certain times if required and oral antibiotics we'll prescribe. And also sometimes we prescribe pancreatic enzymes in the initial days for a proper digestion of the food, what they take. And any other, suppose if they have a cardiac patients, hypertension, diabetic medications, these things also we'll advise how to take.
They have to continue, yes.
And then we'll give a date for their review. If everything goes well, they come on the review date, or in between, if they have some hiccups, they will ask them to contact the team member over a phone or over a WhatsApp call. Accordingly, we'll help them and to recover from this.
To help, yes. So I think we have come to the end of the discussion. Yes, share the slide, Suneetha, first. And yes, sir, as we were mentioning in the beginning that best long-term survival post-Whipple procedure and preventive steps we would like to understand from you how one should protect the pancreas. Maybe the food factor is responsible, or we need to always have the proper amount of exercises, or maybe due to high style attentions to be given. Yes, sir.
So to begin with, we don't know why only some people get a pancreatic cancer. There are several factors. The preventable factors are only a few things in our hand that we should follow. We're following a healthy diet, exercise, and avoiding certain things like alcohol, smoking, those things. See, these are all, there are a lot of tumors happen because of the genetic mutations. That is, that we cannot change.
Cannot anticipate.
Yeah. So those are all the patients. There are also some environmental factors where the lot of food what we consume outside food and all, where there will be some carcinogenic material can be there. But those are all the patients who are having a genetic history and all. We ask them to keep on a proper follow. Patients of a chronic pancreatitis, certain patients they develop a cancer. So chronic pancreatitis patients should be on a doctor's follow on a routine evaluation. They will be attached with some of the doctors, and they keep on assessing, how any malignancy changes happening into the pancreas. And we all know post-Whipples procedure, certain people, the problems, drawbacks, what will can happen in the long term.
Yes.
Suppose some patients they become cancer survivors where they will win over the cancer and they become a long-term cancer survivors. But these people can have problems with the nutritional problems because pancreatic enzyme insufficiency can happen. So suppose the clinician they will decide upon adding an pancreatic enzymes. These patients can present with a steatorrhea where passing an oily motion.
And oily stool,
Yeah,
yes.
stool. So those patients, they might require pancreatic enzyme supplementation. Certain patients may develop diabetes mellitus because you are removing part of the pancreas.
Pancreas, yes.
So periodically, you have to yearly once or 6 monthly once, you have to keep checking your blood sugar levels or HbA1c to look for any diabetes mellitus you are developing. If you develop diabetes, you have to take treatment for it. So periodically, you have to assess for other vitamin deficiencies. Those things also you have to assess. That's how I think we have to manage these patients and do it.
So I think, sir, I thank you so much from everybody because despite of your very busy schedule, you have contributed today. And thank you so much, Suneetha, also. And I think we request all the nurses to just manage these patients with utmost, attention, because as you have heard, many part and many organs are being operated end to end and reconstructions during intra itself. So thank you, sir, and very much
Thank you very much.
honored to have today. And thank you, Suneetha. We end the session today. Yeah.
Thank you, Suneetha. All the best.
Thank you,
Good
sir.
presentation.
Thank you, sir. Thank you so much.